Okay guys, so again, this is the next question. Just pause the video for a few seconds and write down the answers. Okay, so assuming a diagnosis of septic arthritis, you want to do a joint aspiration. What other tests would you request to perform on aspirated sample? So what I do is when I'm aspirating any joint, I call up the biochemistry and microbiology and ask them if they would be able to do a quick gram stain for me and also look for crystals. So basically you're going to ask for gram staining crystal, microscopy and culture. But the two tests which are going to be very useful for you right now would be gram stain and the crystals. What are the principles? So you need to write down the steps. When would you defer a knee joint aspiration? And I would ask the specialist to consider performing it. So some people have written that when you had a failure of procedure, I have never seen anybody failing doing a joint aspiration. So failure of the procedure is not the right answer. Yeah, unless you have never done one and never seen one and you're trying to experiment, which is a wrong thing to do. Second thing, multiple punctures are not required ever. So multiple punctures is a wrong answer. If you are doing multiple punctures, you are not trained enough to do it, so you should not do it. So the answers are gram staining and crystals. You do take consent, aseptic precaution, infiltrate 1% lignocaine at 9 or 10 o'clock position, or at 2 or 3 o'clock position with the knee in slight flexion about 10 to 15 degrees, and direct the needle caudally with negative aspiration. You can use a 20 to 22 gauge needle and aspirate about 50 ml of the sample and send the samples after labeling. When do you not do it? You don't do it if there is a joint prosthesis, if there was a previous total knee replacement, uncontrolled coagulopathy and cellulitis over the joint. Okay, the next one. Pause the video and write down your answers. What radiographic views would you request? Everybody is asked for an AP and lateral, and I had given half mark for that. The half mark was deducted because there are three views always taken in a knee: AP, lateral, and mortise view. What are the pre-reduction steps you would take? So you would give him pain medications. You would move the patient to recess. If you're planning to do a procedural sedation, you will attach the patient to monitor. So pain medications would be oral or IV, because if you're planning to do an procedural sedation, you would rather just do an IV paracetamol and IV morphine 2.5. If you are planning to do it just with the gas like nitrous oxide, then you can go ahead with nitrous oxide and oral paracetamol and codeine. What are the anesthetic options for reduction of his ankle? So as I said, you can do under gaseous sedation or gaseous analgesia like using nitrous oxide. You can do under regional anesthesia by infiltrating around the saphenous nerve, ultrasound guided approach, and the sciatic nerve. And you can do it. You can't do an ankle block. You need to do a higher block. So what you do is you do a saphenous block and you do a sciatic block. You can do it under procedural sedation. If you're doing under procedural sedation, propofol would be the drug of choice because it will give nice cover. Propofol and fentanyl would be good enough. Okay, so this is the answer. Next, take your time, pause the video and write down the answers. Okay, so what we are planning to do here is we are going to do a rapid sequence induction. So name two drugs with doses. So two drugs will be etomidate and succinylcholine or rocuronium, and doses would be etomidate you will use about 0.3 milligrams per kg. So he's an adult, so it would be like 20 milligrams is adequate, and succinylcholine would be 1.5 to 2 milligrams per kg IV. Rocuronium is 0.6 milligrams per kg. So how I remember is etomidate 0.3, rocuronium 0.6. What additional drugs would you consider to this patient. So this patient is having hypotension. So what would you give? You would give IV fluids. He is vomiting. He is in pain. So you can give him IV paracetamol. You can give him IV morphine along with IV ondansetron. What is plan B on the difficult airway society algorithm for difficult intubation? So again, you can come back to the, so you do oxygenation and you do a supraglottic airway device. Okay. In this guy, we can give tranexamic acid as well because it's a major trauma, and tetanus toxide because he's hypotensive. So you must be suspecting he's having bleeding in his stomach. And whenever I see the word major hemorrhage protocol, tranexamic acid is associated with it. You suspect an intra-abdominal pelvic bleeding, so you would give tranexamic acid, you would give a tetanus toxide. And this is the difficult airway society algorithm. So plan A is face mask ventilation and tracheal intubation. If you're successful, it's good enough. If you fail, then what you do is you do plan B. You do plan B, maintain oxygenation and put a supraglottic airway device. And if you're successful, you stop and think. If you're not successful in doing that, what do? You are not able to oxygenate or ventilate, so you move on to the next one. Try to wake the patient up. So you will do face mask ventilation, try to oxygenate and wake the patient up. By the time the effect of succinylcholine goes away, you will be able to nicely ventilate the patient. And if still you are not successful, can't intubate, can't ventilate, plan D is front of neck access. So face, SAD, face, phone. Let's look at this one and pause down for a bit and you can see, you can start writing the answers and then we'll look at the final answers. Okay, so what is your ECG diagnosis? So again, if you go by the ALS approach of interpreting the ECG, rate, sound looks like bradycardia, rhythm, they are regular, RR interval is constant, axis, normal axis, P waves are present, yeah, and P waves are before every QRS, good. QRS appears to be normal, PR segment is normal, and ST, so S is there, I don't see any T, so the wave which follows is P, and P and P are PP interval is also equal, so I think this is a complete hard block. What are your differential diagnosis? In this scenario, the patient is on atenolol, aspirin, simvastatin, and patient is having low BP. Patient is having a GCS of 7 and was not cared by, was living himself. So I would say septicemia could be one, because however they have not given temperature, so you can say septicemia. Second, I would go ahead with lactate is high and it looks like this is a metabolic acidosis, so with a BM of 3.6 and sodium is also low, potassium is high, so it could be beta blocker overdose. So if this was an exogenous ingestion, what medication could be used to possibly reverse it? So you can use glucagon, yeah. So in context of heart blocks, if you see beta blocker, that's, think of beta blocker, think of calcium channel blocker, and think of glucagon. So beta blocker, calcium channel blocker, treatment is give glucagon. The dose of glucagon is 1 milligram to 2 milligrams IV or IM. Yeah. Next, pause for a few seconds and then we'll look at the answers. Okay, what bedside examination would you do for an injury to subscapularis and for infraspinatus? So we are going towards rotator cuff. The four muscles are supraspinatus, infraspinatus, teres minor and subscapularis. Supraspinatus helps in abduction and flexion. Uh, Infraspinatus and teres minor is for external rotation, and subscapularis is for internal rotation. So the Gerber's test you would do for Gerber's lift-off test for subscapularis, and for infraspinatus you will do the external rotation. You have done the examination of the shoulder by look, feel and move. What are the examination? For completeness of clinical examination, you should always examine the joint above and joint below and do a distal neurovascular examination. Non-pharmacological measures you would use, you would put an arm sling, you can apply some ice, you can do limb elevation. Some people have written distraction. She's an adult, it would be very difficult to distract her. Yeah, if it was a pediatric, you can distract. So that's the answer. The next one here, Indian origin. So we are going towards, with the chest x-ray, Indian origin, going towards tuberculosis. Okay, saturation is low and you decide to do a pleural aspiration. So there is pleural effusion over there. Bedside test would be a bedside ultrasound, and two contraindication would be overlying infection, bleeding disorders, patient not consenting. What are the landmarks? Landmarks is below the 7th rib, not the 5th rib, not the safe triangle. Okay, and Light's criteria is it's direct, straightforward. So between the 7th to 9th rib, between posterior axillary line and longitudinal line intersecting the inferior angle of scapula, that's the dependent point. Light's criteria is pleural fluid over serum. So remember this, POS, pleural fluid over serum, and PR 0.5, that is pleural protein ratio 0.5, LR LDH ratio 0.6, and pleural LDH 0.66 to the upper limit of normal serum. If all three are present, it's transudative. That's Light's criteria. Next, pause the video. Okay, so the X-ray shows a Colles fracture and you want to manipulate. So two methods of anesthesia will be hematoma block and Beer's block. You can do a regional block, blocking the radial, median and ulnar nerve separately at the forearm proximally, but Beer's block and hematoma block is much easier and better. So you decide to do hematoma block for this patient. What is the drug you would use? You would go ahead with lignocaine plus bupivacaine or just lignocaine. Maximum dose 3 milligrams per kg. You have gained an IV access while performing the local injection. Now the patient complains of dizziness and we are going towards local anesthesia toxicity here. So immediate next step would be to stop giving medication, shift the patient to resus, start IV fluids, or keep intralipid emulsion next to the patient. Don't give it. Attach monitoring. So the next question here is she has a fracture neck of femur. This is the last question from the mock. What nerves do you intend to block when you do a fascial block? There are three nerves: obturator, femoral and lateral cutaneous nerve of the thigh. Okay. What are the anatomical landmarks? It's straightforward, everybody knows it. 1 centimeter below and lateral to the femoral artery pulsation. What are the components of stop before you block? Read this because this is something which has been emphasized a lot these days, given by the Royal College of Anesthesia, and it is identification of the patient, identification of the site. Just before you infiltrate the medication, you need to do the stop check. So check the arrow mark, confirm the right patient and the right side, and that's the anatomical landmark. And I would like to say thank you to all of you once again. Good luck. Don't stress too much. Just in the last few days, go over this video, and I'm sure you all will do well. And once you finish your exam, do email me or write to us on cmedindia@gmail.com, or write to me at drsajadpathan@gmail.com, and let me know how your experience was with CMED, how was your exam, and all the best for you. Hopefully, I would like to see you soon, either in one of our courses, or as a faculty, or as one of my colleagues to be working in the UK. Good luck once again, and all the best for your exams. I wish you good luck. Thank you.